So again, this is the Small County Cost Report training. It really, I want it to be as interactive as possible for you folks. So hopefully some of you have at least looked at the cost report template or have some experience. And so as we go through this, I want you to ask questions, or if you want to provide examples or things like that, because it's really the more input you guys provide, the better off we all are in terms of learning from each other. On the slide number 1, you've got the agenda. So all the way till 5 o'clock, unless there are just a lot of questions. And we'll take some breaks as we go through it. So first, we're gonna go through just kind of an overview, high level. We're focused on the Medi-Cal, especially mental health cost report, or what now the state calls the Medi-Cal Mental Health Plan cost report. We're not going to get into the revenue and expenditure report for MHSA or the alcohol and drug cost report. We'll talk. So kind of the first part of this is geared around just kind of providing you some information, ways to look at things, and then ways to allocate costs, different approaches, and then we'll get into the actual forms themselves and walk through that, and then finish it off with talking about the settlement process. And we did get some questions that I'll make sure are covered, as well as, again, the more that you guys can ask, the better. How's everybody doing today? Good? I don't know if we're going to end up on the screen here or not. So moving to slide number 2, which again, the purpose of the cost report. What is the purpose? Who knows what the purpose of the cost report is? I'll look at the slide. Okay. The main reason, at least from the federal government's perspective, is to determine the federal financial participation that ultimately is owed to the county mental health plan. In doing that, you're determining your total certified public expenditures. And so really that is the primary purpose. Over the years, purposes to the cost report, looking at general fund and other data collection things, more recently some of the MHSA stuff. But really that is the main goal, is to determine your FFP. The way that that's done is by determining the cost per unit for each service function. And it's really, that's how the costs are apportioned between Medi-Cal and non-Medi-Cal. Again, the state also uses this to identify your sources of funding for the different services, as well as serve as the basis for your year-end cost settlement and your audit. One of the key principles, I think, for the cost report itself is that you want to end up with costs that reflect the services you're reporting. They're supposed to be aligned. So whenever you're asking yourself, should this cost go on the cost report or not, ask yourself, was it incurred in providing that service that we're reporting on the cost report? So that's a key principle, and I'll come back to that as we go through and we talk in more detail on some of this. Okay, moving to slide 3, the overview. So again, the county mental health plan cost report, you've got one summary cost report, and then you've got detailed cost reports for each legal entity. Hopefully that is not new to you. The summary cost report, and we were just talking about that hasn't been released by the state yet, so we're not sure what it's going to look like for 12-13. But it still should compile all the data from all the detailed cost reports. More than likely, you're going to continue to have to report your use of Mental Health Services Act funding on the MH 1995. And then again, in prior years, that's where you identified how much you were spending in various state general fund allocations, both the managed care allocation, when you were getting 80-36-32 allocation. So it'll be interesting to see on the summary if they continue that. And then there's also the detailed cost report that really looks at the FFP for each legal entity. The detailed cost report is, I mean, so it determines the FFP by legal entity, but technically it's required of any provider that is furnishing services, whether it's Medi-Cal or not. Whether you do that is kind of a local decision, because a lot of times, especially with like the board and cares, you're not getting cost reports from them, but you know how much services were provided. So you may actually prepare a cost report on their behalf because it doesn't impact the Medi-Cal reimbursement. But you do want to make sure through all your cost reports that you're capturing all the expenditures and reporting all the expenditures, because more and more I think you're going to see some of this get used to look at performance a little bit, and you want to make sure you're getting credit for all the services that your county is providing. So, you know, also in terms again of an overview, the way I look at the cost report is you really have kind of almost what I would consider two separate but related processes. You've got these schedules that the state created, schedules A, B, and C, which go through and you report various data. A lot of that, you basically have to create kind of a subsidiary system where you're calculating all this yourself using you know, other spreadsheets and so forth to come up with things. And then you got the actual cost report forms themselves. Well, it's all cost report forms, but like the CiMH 1960 and so forth, that really the CiMH 1960, and I'll go into this more, doesn't really do anything but support those schedules. So it's kind of a I call it a bifurcated process where you've got to do all your kind of background work, you're doing it outside of the cost report in order to complete the schedules, and then you kind of back into completing the 1960. Does everybody do it that way? I know a lot of you use Gary's model, which is a good model, but yeah, unfortunately, even with, and the other thing I should say is, this is a new design. This is the second year, 12-13 of this new design, and it's still, unfortunately, unlike other cost reports for other entities, still requires you to do these supporting ledgers and supporting schedules versus, for example, the hospital cost report, the 2552, all the data, you just enter the data into it, and then it cranks it out for you. Moving to slide 4, in terms of the data collection, obviously the expenditure data, so there's which you're going to get directly from your financial system, and then depending on your cost structure, the structure of your cost centers depends on what kind of additional data you're going to need in order to allocate costs. And so you may be looking at staff time, and I'm going to go into these in more detail in a little bit. And you may need relative value data, unduplicated client data to allocate costs. Again, the revenue data directly from your financial system so that you can support that, and then the units of service data. So in the cost report itself, and this is something that I think caused some confusion when we switched from the old format to the new format in 11-12, and everybody knows what I'm talking when I say the old format to the new format, hopefully. You all of a sudden had the ability to allocate indirect costs. Previously, the state had defined all your indirect costs as administration, and technically that was not consistent with federal requirements. And so with the new template that came out in 11-12, which was developed in large part in response to the financial management review that the federal government, CMS, the Centers for Medicare and Medicaid Services, performed in 2009 and released in 2010. So they went ahead and changed that. And so now, and really, a lot of this should be defined by federal requirements, not state requirements. And so this was one where the feds found the state out of compliance. The state said, okay, fine, we'll go ahead and basically identify direct versus indirect costs. And so federal OMB Circular A87 defines what's an indirect cost and what's a direct cost. And then subsequently, DMH looked at OMB Circular 87 and drafted their policy letter 11-01 that applies to how you identify direct costs versus indirect costs. So, you know, just to go directly go to what OMB Circular 87 says, direct costs are those that can be directly identified with a specific cost objective. And so the three cost objectives that you're ultimately trying to get to are services, administration, and utilization review. The one thing, and this is, the state has made this kind of confusing over the years, that direct costs don't necessarily mean direct service costs. And a lot of times in a couple, even in this policy letter, the state kind of mixes the stuff up and talks about indirect costs and direct costs and administration costs. But really, a cost is either direct or indirect, and then once it is ultimately either direct or allocated, it's in a cost center that's either services, administration, or utilization review. And I know, so again, this change, you previously, they just told you take all your indirect costs and call it administration. That technically was not correct, and so now you actually allocate those indirect costs. And so what are indirect costs? Well, those are the costs that are incurred for a common purpose that benefits more than one of the cost objectives. So you've got, for example, well, and we've got some examples here, like legal, HR, procurement, depreciation. One of the ways I look at it is what costs are you incurring because you're the county versus what costs are you incurring because you're the mental health plan. And so, for example, HR costs, those you're incurring because you're the county. The county has an HR function. It doesn't overlap to where you're hiring for your contractors. And so that is an indirect cost that should be allocated. Depreciation maybe, procurement is another one if you're cutting across all the different cost centers. But you'll see when we go to the 1960, the list of the different cost centers, what they're calling indirect and what they're calling direct. Your countywide allocation, your 87 costs, are typically indirect costs that you're going to allocate because you're not identifying. It benefits both administration, UR, and your service costs, and you don't identify a specific amount initially from your financial system to each of those different cost objectives. So does everybody kind of get that? I mean, you know, a lot of, again, when you read that policy letter, it kind of interweaves this administration versus indirect and direct costs. But I think it's real critical to think of, you either have a direct cost, so I take it from my GL, my trial balance, whatever you want to call it, and I can identify it to one of the objectives, either providing services, administration of the mental health plan, or utilization review. And so if I can directly identify a cost, and probably I would say the majority of your costs are going to come from your trial balance or GL and be directly identified as a service cost. I mean, that's all your clinic costs. For those of you that have contractors, you're going to start off reporting all your contractors' costs like that. So those are the majority of your costs. Administration is a little bit more difficult because, again, and actually I'm going to talk about that on the next page. Let's move to the next page, on page 6. So talking about the cost centers. Again, you know, your service costs are your cost of your clinics, of all the services you're providing. Administration is really administration of the mental health plan. And so those, the state has defined as, which is actually very interesting, they're defined similarly to what are defined as the Medi-Cal administrative activities, Mode 55 activities. So things like outreach, eligibility intake, contract administration, program planning, policy development, administrative case management, claims administration, and then development of your claims processing system. And really, these are things that, these are costs that you're incurring because you're the mental health plan. So program planning and development, I guarantee you, your mental health director is involved in program planning and development of your overall Medi-Cal, especially mental health plan. So some of that time, the director's time should be allocated to administration in that fashion. To the extent you're doing, you know, probably a lot of you have done new claims processing systems, short L2, you know, over the last couple of years. All that is because you're the county mental health plan. Contractors don't have the ability in mental health to submit claims directly to the state. They all have to run through you. So those are examples of costs that are considered administration. And then technically, utilization review is another thing that, in fact, in both of this, both the administration part and the utilization review part, more so in the utilization review, there's reimbursement for utilization review where the state has delegated that responsibility to the county. So the county's responsible for chart reviews and all of that, both with your county and your contract providers. And so to the extent that you're incurring costs doing that activity, you would identify that as utilization review. So does anybody have any questions on like the indirect versus direct, the admin service? Yeah.
So I do. In the past, we have always stepped down our IT costs to our direct service.
Okay.
And so the development of an electronic health record and the data collection that we do, we've always considered that part of our direct service cost. So there's this.
So the development would be questionable, I think. The actual doing it in data entry, that sort of stuff, I could easily see stepping down those sorts of costs because those are the same thing that a contract provider would potentially have to do to submit an electronic health.
Right.
So I mean, that's kind of how I look at it. You know, I think it would be questionable if the auditors came out and looked and saw that you took the development of a system and stepped it down into direct services, unless the system was solely, let me think about this. In your case, you guys have contractors, so, right? You have contract providers.
We do.
So if it is for the entire system, for both county and contract providers, I think you'd have trouble justifying stepping it down just to the county direct services. You'd have to allocate some to the contract providers, which again is why it's really part of right, the mental health plan cost. Now, I know some of you don't have providers, and so, but you'd still look at it in the same light. If you had a provider, would this be benefiting them? Would they be, you know, participating in the same thing? And if they are, then really it's part of being the mental health plan versus really just being a provider of services.
Okay, that's an important distinction. When I looked at A87 for the the OMB 887 guidelines, they're so subject to interpretation. And I wonder if there's anywhere that we can drill down more specifically, either to support our case or to have an understanding of what indirect costs we can step down.
So, the only other thing would be the provider reimbursement manual. And then the DMH, DHCS, DMH guidance. And that's
5 or 6 years from now.
Right.
When we're audited.
So I don't think there really isn't, you know. So you're more interested in identifying, so, because the indirect part is pretty, does it benefit more than just services? So I think a key, what you need is you want to know what's administration versus what services.
Right.
Because then that would define whether, you know, you would go ahead and step something down, or need to step something down. And you know, again, all the states really said is it's these various activities, which includes claims administration, which again, when you talk about claims administration, that isn't entering necessarily the claims into your system. If your contractors do all their own data entry, and you do your data entry for your, you know, your own county claims, that's not claims administration. Claims administration is, you know, running the 837, submitting that up to the state, trying to reconcile back with the 835. That's really the part of claims administration. So the best I can say is to take a look at whether, is there a benefit going to your contractors, or so you're doing it because you're the mental health plan, versus it's just benefiting the county, like an HR function, because you're not hiring for your contractors. You're just hiring for the county mental health. So that is an indirect cost that can get stepped down. But you're right. I mean, OMB Circular 87, it basically says what I just said. It's like, can it benefit more than one cost objective? Then it's considered an indirect cost. And the cost objectives in our case are services, admin, and UR. So is it benefiting more than just services that you're showing on your cost report? Then it would be considered an indirect.
And so are we going to, so I see we are going to talk about cost allocation.
Mm-hmm.
So how you would, okay, thank you.
Hey, Mike.
Yes.
On what you was talking about for their software development,
Mm-hmm.
Pretty much anything we do to our system applies the same to our services as it would to our contract services. So the argument can be made that even without the contract services, you'd have to do the same work, which would then relate only to your direct services. Couldn't you use that argument? It really doesn't. You have to pay the money to get the system to work the way it's supposed to for your services, and just as an adjunct, you're able to utilize it to fill out your contractors.
But the reason you have that system is because you're the mental health plan. So, you know.
But if you weren't providing the services, you wouldn't need to bill. So then you wouldn't need a system. So why is that not a direct cost?
If you weren't providing services, but you were still the mental health plan, you would need to bill. I mean, the way to look. This is another way to look at it. The mental health plan is like an insurance, like an HMO, and then either you contract to provide the services, or you decide to hire, even consider it a separate entity of your own people to do the services. But you really have this entity that's like an insurance organization that does the claims processing, manages the network, you know, those sorts of things. I think it's hard to argue that those costs should only be, because the other part of it is too, in OMB Circular 87, you need to allocate it based on the benefit received by that corresponding cost center. If you're benefiting, if your contractors are benefiting from you developing that system, technically you should be allocating some of the cost to them. And there's no way to do that on the cost report.
No, it's not.
So, which means you're over allocating to your direct services. But I will say there's definitely gray areas here. I mean, it's not, you know, cut and dry, because you also have to look at, you know, what data you have available, and how hard is it to collect it. You know, are you going to ask your director to sit there and record every micro minute doing these different things, or, you know, if you've got one staff that does a whole host of stuff, you know, is it worth it versus just, you know, putting it in the cost report as either services or administration. So, I mean, there's definitely a you know, kind of cost-benefit analysis of doing that. So, yeah.
So I'm making the assumption that we're talking about systems, electronic systems. You refer to claiming.
Mm-hmm.
A lot of us would have a electronic system that would, the majority of which would serve as our electronic health record, and a piece of that happens to facilitate the claiming process for us. So looking at it that way, when you're talking about, now you're talking about the health chart, maybe possibly looking at it from that perspective, when you have a system that benefits both your clinical health record, which would be very much direct service driven, and then you have a piece of it that is claims processing, which would be administration, because it at that point is benefiting two cost pools, potentially.
Mm-hmm.
Is then an indirect service, and then would be to
right. So you would identify that cost, and you have to allocate it.
Right.
So yeah.
And is the I'm assuming because of the spreadsheet doesn't really allocate anything for you.
That's correct. So that's why, you know, when I was saying it's kind of bifurcated, it's like you got to run a parallel system where you're calculating all this stuff, coming up with what are, you know, I'll get more into that.
Yeah. Okay.
And then this is a relative value question, which I'll address in a little bit too.
Mike, on the administration piece there, where you have outreach and eligibility and contract program, well, mainly those things in administrative case management. Is that what you were referring to as a lot of times MAW?
Yeah, it's the exact same definition of what MAW is. That's what, so it's kind of the same, the state has defined it both places, either as Mode 55 or as administration at you know, the higher level.
But that is different than from mental health promotion and
yes.
that set of.
Yes.
Because most, I think, at least with a lot of the counties that I work with, the smaller counties, is that most of our stuff falls into community client contact or mental health promotion rather than this type of administrative stuff. We don't do MAW, per se.
Right.
Like Mode 45.
Right.
Yeah.
Right. Yeah. No, it, you know, you're definitely going to have Mode 45 type of activities as well. That is not what this represents. I mean, for a lot of you, especially the smaller ones, this could just be predominantly just your mental health director, and maybe with a little bit of claims administration or something that's defined as true administration.
And that's what I was going to say too, is that with the smaller counties too, that we allocate a bit of secretarial time or program, what I call program support, and all the other things. And this year we had an issue with the audit on that process of not allowing any of those costs for UR. Even though we allocated, you know, used the same allocation methodology, we got dinged on the audit, and because it was such a small amount, we didn't go after it. but I know our director, and I got that question to Chuck, that the auditors, even though the DMH letter that talks about UR allows support staff at the 75% level, and if we don't use the 75% level, which we don't in most of the counties except for the professional part, the support part, we just allocate based on labor that's in there. Mm-hmm. They get a part of everything, and they completely disallowed it this year. Just the whole thing, as like you didn't have any documentation. Well, it doesn't say what kind of documentation you have. We just used an allocation methodology. Right. And so, and Chuck basically seemed to agree that it's got to have cost too. Right. We're not claiming. Now, I can understand that with the 75%. You know, that's a little bit more picky about that, but not that just the general overhead. But they didn't allow me to allocate any building or anything. I mean, yeah, no, it's unfortunate, but it's not correct. Yeah. Because you should be able to. And I mean, I don't want to get into discussion on the auditors. Yeah. But that, for us, that would be good to get clarified at a higher level, instead of having to go through all of this extra work. Because this is what, and the thing that bothers me, it's been like for 40 years. I mean, they've been allocating it like that, and all of a sudden, no. And that doesn't come from every region either. Right. I mean, you know, again, we could probably spend a couple hours talking about the auditors. There is not consistent standards that they apply, and there should be. I mean, not any other program. Most programs have standard audit procedures that the auditors have to follow, and unfortunately, in our case, that isn't true. And like you said, you could be in a different region. You could probably have the same supervisor with a different auditor, and it may be applied differently. Not just this, but you know, how you're determining your Medi-Cal percentage is another thing that's been really big lately. Using unduplicated clients, services, relative value, to where they haven't allowed unduplicated clients in some cases, but other times they have. I mean, it's frustrating for you guys because yes, there are some gray areas that require some interpretation, but some of these things are pretty clear cut. Allocating your indirect cost to the cost centers that benefit from that indirect cost is a simple principle spelled out in all the federal, guidance, and a lot of the auditors don't even get that. And then you point out that the reason there was a change is because CMS did a review of the state and found out that the state was out of compliance. So the state's been out of compliance for however many years, and now trying to bring them back into compliance, and they're not applying it. It's like, anyway. So there's something else you made me think of, but I lost it. So in terms of the cost allocation, and this is just what we were talking about before. I'm on slide 7. So you got to identify basically the allowable cost for each service function, because that's what feeds into this Schedule C, and it kind of creates, like I said, this parallel process or bifurcated process, but they're kind of related, for completing the cost report, where you're forced to basically prepare a separate model that comes up with your service function costs, so you plug those in, and then you kind of got to go through the rigmarole to fill out the forms to support those service function costs. And hopefully they're aligned. So in terms of, after you identify your allowable costs, you have 3 different approaches that the state allows you to allocate between
between the service function codes for each legal entity. One is to if your financial system directly identifies costs by service function. Everybody knows when I say service function, everybody's good on that. If your financial system, and I think I've seen this once in the last 27 years, where they could identify, or at least look like they were trying to identify the costs by service function. So they had a cost center called case management in their financial system. But generally, that's not the case. More than likely, either you're doing a time study, and the requirements to do a time study are 2 weeks out of the quarter using a representative 2-week period, and then you come up with what are the staff costs of each service function, come up with percentages, or the relative value. And that's where you're taking the units of service and applying a weighting to those units of service, which in this case is the applicable charge, to come up with a relative value for each service function. So on slide 8, I've got an example of how you would do a time study. And what it does is it shows the hours of 2 different employees. You'll notice that they did have some time for administration and paid time off. You basically ignore those because they just get absorbed into the direct services. And you figure out, okay, what are my service hours? Apply those to the different salaries of the different employees to come up with the cost, the salary cost associated with each service function, and then add those up for the 2 employees, divided each service function by the total to come up with a percentage to use to allocate costs to the service function. Yeah, Kim?
Real quick, allowable costs, they're all defined on A87.
Provider reimbursement manual, and I'll cover that a little bit more when we get into the actual forms. Yeah, this is, you're now, by the time you're allocating the costs, you've already done all the adjustments and everything else that I'm going to talk about in a minute. And this is just one of the approaches to take your service costs and allocate them into the different service functions. So is this what you use in your model, Gary, for the most part? Or you're using this, right?
Yeah, in most of the counties, there's a couple that we're using relative.
Okay.
But most of those systems are able to do the one like you said there. It's really a full-time study because they do all of their dailies through the system and it accumulates those costs.
The one thing about the time study that to me is interesting is that it actually allows you to start to use the cost report almost as a management tool as well, because all of a sudden you start to see case management costs more than crisis. You go, why? Because you got docs doing case management when they should be just doing crisis and med. So the nice thing about the time study is it does give you an accurate representation of what the staff are doing, and it's basically weighted by the pay of the staff. So if you do start to see case management, again, higher than mental health services or crisis or meds, it can raise some red flags that, what's going on here? Why are we having such highly paid clinicians doing case management? The other approach, oh yeah, there we go. Thank you. The other approach.
Don't notice the clicker work, so I'll let you.
If I touch it, it starts smoking?
It will start smoking.
Okay. So that was. So here, we just walk through it. You got the hours. You ignore the administration and paid time off because they just get absorbed into that. So by ignoring those, you're basically prorating them across. come up with the percentages based on just the service hours, apply those percentages to the salaries to come up with the cost of each service function, add it up for each service function, add up, get the total, divide the total into each individual one, and you come up with your allocation percentages. And again, in looking at your model here, you capture this by employee, and
right.
So especially in a relatively small county, this is not that difficult. This does become more difficult the larger you are, because obviously the more employees you have, the more data you've got to compile.
And there's a couple of the bigger counties like Merced, they use that, and in Mendocino they also use that, but they've got it even hooked into their other part of their system that it automatically loads it.
And that's so if it's automated, it's great. The problem is when this isn't automated and you've got a key or you've got to create a bunch of formulas to pull stuff in, that it becomes more cumbersome when you've got a lot of employees. But it is probably the most accurate or of the allocation approaches. We then also have relative values. So again, the concept behind relative value is that each unit of service is not equal. So a unit of case management is not the same as a unit of meds. In our case, a unit for outpatient services is a minute. So a minute of meds theoretically should cost more than an hour of case management. So you take, because otherwise, if it didn't, if all the services were the same, and the inputs into those services, the cost of the inputs into those services were the same, then you could just allocate based on total units. But because they're not, you take the total units, you weight those, and in this case, using a published charge, or your usual and customary charge, since there are no more SMAs, I don't know how you would say you would use the SMAs unless those were your published charges. So previously you used to be able to use the SMAs. Before that, you also could use negotiated rates when we were able to have negotiated rates. But now, since we don't have SMAs, you really want to use your published charges. You multiply the units times the weighting factor or the published charge to come up with the relative value of each service function, add those all up, and then divide the total into each individual service function to come up with the percent of costs that go to each of the service function codes. And so the other problem, to be honest with the SMAs, those were established based on data from 1993 and 94, and then were assumed to those same proportions between case management, mental health services, meds, and crisis, that relationship still held true as of, when did they get rid of them, 11/12, which is a real long time to not go in and take another look. But the only way to really take another look is if everybody did it based on a time study or tried to determine real actual costs. So in any case, you should be using something to weight the units of service, preferably your published charges or your usual and customary charges, to figure out the relative value. How many people use relative value here? So quite a few. I mean, it's to be honest, it's pretty easy.
And the other thing is, like you say, it does artificially, if you're looking at it as a management tool, this hides the problem area.
Mm-hmm.
Whereas if you go with the study, like we have in some of the other counties, it does show, for example, case management being higher than other costs. Well, that has to do with a productivity issue, documentation issue, or something like this. And this you would never find that when you set up your rates ahead of time, so to speak.
Right.
and then just base it on those rates, it always hides that.
Yeah, yes. And the other thing, you know, although it actually would work out when you add it all up, I was thinking this could help you when we did have SMAs come in under the SMAs, but not necessarily. So everybody understands how to do relative values. Yeah, Kim?
So there are other methods, especially under this new process where we don't have the SMA anymore.
Mm-hmm.
My question is, if you take a total program cost and say it's the meds division,
Okay.
who mainly what their function is to provide medication support. But as you said, sometimes they feel very therapy-like and they want to do some therapy work as well. If we were to take those costs, and because we know what direct services were generated from that program, we've made a cost pool based on the meds clinic,
Right.
and then said, okay, we know what services they provided,
Right.
and then allocated it to those service functions. You can still kind of say that's the relative value method if you...
But you're just doing it at a program level,
Yeah.
rather than at a legal entity level.
Right.
Yeah.
So that's still the relative value method because we're not saying, okay, you did this, you did that.
Yeah, and again, it's more accurate than probably taking it at a macro level, you know, for the entire legal entity. So, and especially in a larger small county, where you do have multiple sites, multiple programs, you know, it's going to be more accurate if you're doing that. And you can. There's nothing that precludes you from doing it that way. As well as the other reason for potentially doing that is the difference between an MHSA program versus a traditional program, because you may want to look at costs differently in the different programs. Yeah.
So what I've noticed, though, is that it's, although we do direct cost allocation through time study, when we get to the cost report, we always look at, like mode 15, looking at relative value to see how the FFP would be reimbursed through that method. So I think it's important that counties look at both options when they're preparing their cost reports.
Yeah, you know, technically you're supposed to stick with one approach, and then if you want to change, you know, tell the state that you're changing. I don't know if anybody approves it, but so if you were constantly changing, it may raise a red flag. But yeah, it's definitely something to look at because, again, you know, if you're doing, for example, the time study, and you come up with a ton of costs or case management, but then 100% of the services are Medi-Cal, well, that's going to be a better result on your FFP than if you use relative value and push less costs, assuming that your other service functions are not 100% Medi-Cal. So it's definitely worth, you know, taking a look at it. So.
Well, especially since the SMA's gone away and it's gone to cost.
Right, right. So whichever service function has the highest percentage of Medi-Cal services is where you want to have all the costs. But, you know, yeah. So it's definitely worth looking at. Yeah.
There's a question from online. What exactly is considered published charge? We have contracts that don't have published charges. Can we use contract rates?
So, so could a contractor use the contract rates to do this if they don't have a published charge? And yeah, I would think the answer would be yes, to do the relative value for a contractor, because they've agreed to, or both parties have agreed to that rate. So technically they might not have, quote, a published charge, but they should have a usual and customary charge, which I'll get into in a little bit when we talk about lower cost or charges. But in any case, using a contract rate, a contractor using the contract rate with the county to do relative value seems appropriate. I mean, again, you're weighting the services based on a factor that you would think would reflect the inputs into that service. And what, I mean, I don't want to get you guys all confused and stuff, but this is very similar to using kind of a cost to charge ratio, which may be where we're going in the future. So in any case, that's the relative value. Okay, let's get into the forms. So, like I said, we've got the schedules, and I mean, generally, I mean, Schedule A is a piece of cake, but generally, I do the cost report, and Gary, I'd be interested in your input in the order in which they're in the thing. So you do Schedule A, B, C, then you do the 1960 and so forth in terms of how you actually do them. But again, before you even get here, you've kind of done some sort of model that got you to what your service function costs are from your financial data that's in your financial system. So does everybody pretty much follow the way they're in the, I mean, Schedule A, don't look at Schedule A, but basically doing the A, B, and C. B is pretty easy too. C, the cost, and then going on to the actual MH 1960 and so forth. So really with Schedule A, and I'm going to leave the form up while I talk about some notes on the other slide. So there's really, on Schedule A, there's a couple of things. We've got the published charge, we've got this county non-Medi-Cal contract rate, and then we've got the eligibility factor there that you're completing. So you'll see on slide 11, you know, what is your published charge? And this is something that CiMHDA, we've been trying to push the state to define truly, because technically that isn't your published charge. That should be your usual and customary charges. The state's used the wrong nomenclature for years. But so we've tried to push the state, and so what ends up happening is you put your published charge in here, and then this is where it compares later the lower cost or charges. We've argued that technically there are provisions in the provider reimbursement manual that allow for government providers to basically say you don't have a usual and customary charge. Everybody you're serving is basically either Medi-Cal or you're under contract to serve them through your performance contract with realignment. There's nobody you're serving, at least at this point, outside of those arrangements. And so therefore, we shouldn't even have to do this. But right now, you do have to do it. And so we will keep pushing that, you know, as long as we can until hopefully we get some clarification, because this is another one of those areas that's really a gray area. But again, I think the key to note is it doesn't have to, quote, be published. It's your usual and customary charge. But for a charge to be usual and customary means you actually have to charge it to somebody and collect it. And so how many of you actually charge your full fee to one of your clients and actually collect it? Probably not a whole heck of a lot of you, because that's not the way that we're set up. So anyway, but generally people just put down whatever, you know, you do go to your board, you do get some charges approved, and that's what you plug in there. The county non-contract rates, I didn't put it on there. So this is basically used for the allocation of costs later, if for non-Medi-Cal services. So if you contract with an entity for non-Medi-Cal services, you can put a rate in here, and you'll see later on Schedule C, when you select rate for allocation, it uses that rate to allocate the costs. And then lastly, the Medi-Cal eligibility factor down here. which is just for MAW services. Who's certified or has a MAW claiming plan? Does everybody, Napa, anybody else? That's it. So, so for most of you, don't worry about it. But Napa has to do the Medi-Cal eligibility factor for the MAW services.
So, really interesting question. The form actually calculates the percentage for you?
So,
is that what you're saying?
No. So, and it is kind of, so with MAW, you've got to submit your quarterly claims or invoices. And really, whatever you're coming up with as your Medi-Cal percentage for those claims should be what you report by quarter. And then this average is what gets calculated and then applied. And so, to a certain extent, unless they've changed it, they're applying this average, even though your quarterly claims are more accurate. So it's kind of a weird thing. But yeah, you need to enter. I don't think you enter the average. At least you didn't have to. I didn't test it in 12-13, but you just enter in for each quarter, and then that gets applied against your Mode 55 costs.
I just mentioned that because of their issue that they've taken with the way we calculate the percentage recently.
Right, and so, you know, the MAW manual says you got two ways. Either use the way that they're currently pushing you, which is the percent of your total county population that's on Medi-Cal, which is typically a pretty small percentage, or you should be able to use, I forget if I put that in here later, basically client count. So of the clients you're serving, how many are on Medi-Cal? And where the auditors, I think, have come at this is that we are not documenting everybody you're doing outreach to, so therefore that isn't representative truly of your Medi-Cal percentage.
They're taking a position of only using non-open clients to make that number. So, but
wow.
Of course that would be an audit discussion. But
yeah, no, it's. I mean, and going back to why MAW was established, partially it was because we have these SMAs, and we're doing all these other things, and so we're bumping up against the SMAs. This is a way to get around that and get some additional reimbursement. It was set up as a service function almost initially to be similar to, like, you know, case management or mental health services, and that you're just allocating costs. But the state has taken a different view over the years of MAW, unfortunately. So again, Schedule A is pretty straightforward. Anybody have any questions there? I went through this, the published charge. Yeah, there we go. That's the Medi-Cal eligibility factor, which again, the actual head count is in the MAW manual. And the other thing with MAW, and for those of you who aren't doing it, I wouldn't recommend doing it. So, especially now, again, with the estimates going away, and I'm not sure long term if we go to case rates or capitation where MAW fits into that. So anyway, but the MAW manual, it really comes down to what's in your claiming plan, and if they've approved it, I don't see how. Anyway. So Schedule B is basically, you know, this is where you're putting in the units of service, and the third-party revenues is offset to the various programs. So we start off with the settlement type, and for the majority of you, at least for the Medi-Cal services, it's CR for cost reimbursement. There is also the option, and so the settlement types over here. You can put in TBS if you've got a organizational or group provider that only does TBS services, in which case they're treated as if they're like one of your network providers or your fee-for-service Medi-Cal providers. That is, ASO is another one, which is treated the same way, as well as the MHS. The one thing, and Gary and I were talking about this earlier, with the ASO, one thing that changed in 2011, 12 is that you had to start pulling out the administration portion of that ASO claim and reporting that as administration rather than direct services. But for the direct service part, you would just put ASO, and that gets reimbursed based on your payments to the ASO. You also, for NAPA, you put MAW for your MAW stuff. And then, what else do we have?
Also, is hospital in there yet?
Hospital's on here, so most of you are not going to touch hospital, except for you guys in Humboldt, because
if they haven't fixed it this year, and I haven't run it this far out yet, but for 11, 12,
yeah,
this year we had to use hospital for the contracted hospitals to make it so it works.
Yeah.
for the
Yes, if you put in that service mode and that service function, you had to call it hospital, it wouldn't work.
It wouldn't work.
for the which contracted hospitals?
It would be like all of your
The fee-for-service Medi-Cal?
fee-for-service hospitals, yes. They did not have Medi-Cal. That would be their indigent clients that we sent there.
Got it. Okay. So what you had to report, you had to use the hospital to report the non-Medi-Cal services.
Otherwise, you couldn't get it to clear
Right.
the little
Right.
error on top.
Okay.
The way that the form works, if you look at the cell referencing, you
Yeah.
have to use that or it won't calculate right.
Okay. And did you get the 2552 from those hospitals, or?
Oh, you just did it. Anyway, that's what they've accepted so far. Only that. We didn't do anything else on all those other forms at the bottom.
It's still calculated right on the 1966 and stuff. You just had to call it
Yeah.
hospital on the Schedule B.
Okay. But you also had to put it on Schedule C then, how much you paid them.
Yeah.
Yep. Okay. That's why it would work.
Yeah.
Okay.
I don't know if they fixed. I haven't seen that. I haven't put anything in for this year, so I don't know.
So that would, I was thinking it would just be Humboldt because their PUF is actually a certified hospital that does Mode 5 service function 10 through 19. All the other PUFs other than Santa Barbara's are not considered hospitals, so would not be HOSP. But what Gary's talking about is when you pay one of the fee-for-service hospitals that's reimbursed outside of our system for the Medi-Cal portion, if you pay them for indigent care, so for non-Medi-Cal, again, it kind of goes back to you want to get credit for those services, so you would use the HOSP on here, but you would have no Medi-Cal services. It would just be you have total days for the indigent care. There's also an ISA for Integrated Services Agency, which I think goes back to an old LA program. Does anybody do you ever use ISA or anything? No. As well as there's the CalWorks CAW option, which really doesn't do anything different, but you can use that as well. And then obviously you've got the mode and then the service function codes. Some of the stuff's drop down menu. You know, in some cases, so with the outpatient services, some counties break out mode 15 into the old service function codes that we used to have: collateral, assessment, individual, and group. You're not required to, but you can if you want on here. You know, so we start off, then you plug in total units of service. It's nice. They did get the time period at least correct now, so you're not having to break that out into multiple time periods. Unfortunately, 11-12, I think you did, even though there was the FMAP, the percentage reimbursement was the same during the different time periods. So you report your Medi-Cal units, your straight Medi-Cal, and your Medi-Medi crossover, and then any revenues that you receive that should offset You then do the same for all these other programs, and all this is driven by the aid code of the client receiving the service. So, and there is a master Medi-Cal aid code chart on the DHCS MedCC library work website that you can look at to identify those. But you do want to identify this enhanced generally is 65% FFP, some are 100% FFP, and then the healthy families, which is 65% FFP, and then the balance is non-Medi-Cal. So one thing to be cautious of is that my understanding is that the auditors are looking closer at your distinction on these units of service, and even though from your system, from your claims processing system, you're just saying, hey, it's Medi-Cal, I'm just going to put it in short-term Medi-Cal, versus actually there's a Medi-Medi or enhanced children. I heard they're actually disallowing services that aren't in the right place if you can't support that through your claims processing report.
Yes, they are.
So.
But the recent audit I had, they looked at the Medi-Medi units and your Medi-Cal units together because they recognized that they had a hard time breaking those out.
But for the other ones,
The other ones they don't have the right numbers in the bucket.
You definitely want to try to identify those separately. And then in healthy families, so again, this is all driven by aid code. Did anybody here transition to healthy families in 1213? Or because it must be, okay.
You mean transition away from?
So the healthy family transition where all the healthy families kids are now Medi-Cal.
Right.
For most small counties, that didn't happen until 1314.
Right.
Partially happened.
So you would just, so this would only be for the kids that were still in the healthy families, and then the rest would be the enhanced based on the aid code because their aid code switched.
Right. And it's always been based on the aid code, and as they moved over, all that happened is their aid code changed.
Switched,
and
right.
That's what we were always using as an indicator, so it's not going to be too much different.
And your system control that. And
yes.
Anybody else transition during 1213? Again, most of you would have been the final phase, which didn't happen until 1314. So in terms of, actually, this is, how do you identify the units on here? You know, the state historically has said they wanted that based on, you know, your 835 and have that support from your 835, your approved services. I think you can make the argument, at least on the initial submission, that the units that you report here are what you've certified you've incurred a CPD for the Medi-Cal services. I think you would definitely exclude anything that had been denied. But if you've got units that either haven't been billed or are still in process by the time you're doing the cost report and you think they're going to be approved, I would include them on the cost report. And actually, to be honest with you, and I'll talk about this later, for the initial submission, it kind of doesn't really matter. And then also you're reporting, again, the revenues for each of these different programs that go to offset the services that you provided and identified.
What's the difference between the CR type and the MHS type?
So, actually, good point. So the MHS are, I call them your network providers, your fee-for-service Medi-Cal, your psychiatrists, psychologists, you know, those folks that you're paying a flat rate and you get you pay them whatever, and you get reimbursed based on what you paid them versus them having to do a cost report. Now, yeah. So that's 1213. Or, yeah. So that's what the MHS is. The ASO works the same way. Those in TBS, you're going to get FFP based on what you paid the individual practitioner versus their actual costs.
Those also show up then on the program 2.
Program 2, yes. When we get to the 1966. Okay, any other Anybody have any difficulties kind of with this one? Hopefully, you know, most of the time you're able to generate this from, you know, your claims processing system in terms of the units. So, all right. So there's some more notes on all the different settlement types that I just covered. And then Schedule C. So this is where you're going to be entering the costs. And unfortunately, when I cut and pasted, it didn't come out real pretty. But this box here gives you where you identify the allocation methodology. And so what you do there generally is there's three options. The rate for allocation, the published charge, or directly allocated. The rate for allocation, if you remember back to that Schedule A where I said there was that county non-Medi-Cal contract rate, if you check that box, it will use those rates to allocate your costs. If you check published charge, it will apply the relative value approach based on your published charges. And probably what most of you use is the directly allocated method, which then just allows you to plug data directly into the form itself. Because you've done this parallel process to come up with your service function cost. And so then, and I always get confused, these titles aren't the best. Eligible direct cost and directly allocated data. So the settlement type mode, all this stuff comes over from the Schedule B. You're just plugging in costs into one of these two columns. What goes into the eligible direct cost column are the TBS, the ASO, the MHS, and the CalWorks costs. That's what you would plug into here. And those don't get reallocated in any sort based on what you check there. You can also, if you want, put any of the non-Medi-Cal modes, so any of the Mode 45 or Mode 60 costs, you can plug in to that column as well. The other costs, your cost reimbursed stuff, all goes in this directly allocated data. And then look at this box to figure out how to potentially allocate those costs. So again, if you put costs here and check directly allocated, it's just going to take whatever you entered here as being the allocated cost. If you put directly allocated costs here and check published charges, it's going to add up all those costs and apply the relative value and reshuffle them to get to the allocated costs here. Does anybody use anything other than directly allocated or whatever? Yeah. Anybody use published charge or everybody just? Yeah. I think they tried to do this because a lot of people were using relative value, and it kind of made it an easy way to do it. So you didn't actually have to figure out the relative value. But still, the bottom line is to put a service function level cost in there, you already had to have done it. So it kind of defeats the purpose of why it was created in the first place. The other part of this to pay attention to is really two things. So we've got up here where it's saying, here's how much your cost, it's comparing your costs on the MH 1960 to what you're coming up with here. And if they're off, it's showing an error. The problem is, it's like if you're off by a penny, it's showing there's an error. And so if, you know, I mean, I think I got it right once. And it's, you know, the numbers, you'll look at them, they're the same number, but because of all the multiplication and other stuff, it's not gonna equal, which is really too bad, because that could be a nice little check. The other part you're going to want to take a look at are where it does aggregate these costs down here in the bottom, because you can then make sure that this is tying, and it should, back to your work papers, how in terms of how you came up with the cost by each service function to start with. Any questions on this guy? And so, you know, the other thing, it's based, and this is why, you know, talking about the hospital and why it works is because this is what populates the 1966, not the 1960 through 65. So really this ends up being more a driver of your cost per unit and your settlement than the 1960 through 65. In those forms, which I'll go through next, basically are just to support what you've come up with here, and they don't really do anything. They don't go anywhere, which again isn't really the way it should work. But anyway, so again, you go through and do this, and the other part, completing the actual cost report itself. How many of you spend a lot of time doing the cost report forms versus spend time compiling data to get it to go into the cost report? I mean, most of your time is typically spent compiling data to get to the cost report. So the cost report itself really isn't that difficult to populate. It's more doing some of the other things to get there. You guys want to take a break? Yeah, why don't we take like 15 minutes? Quick break, and then we'll go through the MH forms. Yeah, so we'll start at 7 till.
They detailed it out.
Yeah, little. A little bit.
Yeah. I think that was.
No, we're doing what you said. So whatever the administrative costs were.
Now they.
I didn't know if you would.
We do all the work. This step of putting it
You think what else? It's okay.
So I basically say, you guys, you're identifying.
Oh, it's me and you. Source like.
Right.
So in our case,
Revenues come back to you. So you might make some adjustments with them that. The plan to have. It is, but you're not hiding anything.
Oh, there you go. They'll be around, may not.
It's already broken down.
I mean, I don't care. For me.
Who would we need it?
If you were willing to
My revenue's mentioned. So this kind of stuff, some stuff is to allocate costs. Intelligent question.
Yeah, and
Mental health specialty. That's why I told you allocation is right. You can be allocated, so the one informant, you can plug it in, and then you get the other. So we're doing things right. It's just, it's how you allocate your day.
Go for it. I've been sitting all
No, 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 yo me la comí. No, ya me comí la mía. I'm serious.
last year was really the first year that I thought I could reconcile. I didn't write it too well.
Hello, hi, how are you doing?
How are you?
Fine. Joy.
I don't know, we're spoiled.
That works for me. I mean, it's more different. So moving on to the 1960. And so again, so we've got these series of forms, the 1960 through the 1965, that basically support what you just entered on Schedule C. And that also these forms tie back specifically to your financial system. So we used to have in 1960, the form numbers really haven't changed much in 20 years. But we used to have a 1960 that you actually would do a bunch of adjustments from your trial balance or GL before you got to the MH 1960. And when CMS came in and took a look at what the state was doing, said, you can't do that. We want you, you should be able to run a report right out of your financial system that ties to where you start on the MH 1960. And so that's when the state started modifying 2 years ago in 11/12 the MH 1960. So you start off with columns A and B, where you've got salaries and benefits, and then you've got other, and then it automatically sums into the total. Those need to tie to your financial system. You shouldn't be making any sort of adjustments to get to here. It should be literally print out whatever your cost centers are and however you're organized, print it out, and it ties, or generate a report, and it ties to what you are reporting here. And so you can see we've got a bunch of these indirect cost centers up top here, and then we've got what are called direct, the direct cost centers. That's why we spent so much time earlier talking about this, because ultimately, when we get to the end of this thing, everything's going to be in a direct cost center. And so it's a matter of some of this indirect, and ultimately then how you allocate that later on the form that is shown on here. So you go through your financial system, and it really depends on how you're structured, depends on how you're reporting costs into these cost centers. So for example, your direct cost centers, and again, the main one is at the very, or second to last bottom line, where you've got the non-hospital mode costs. That's all your service costs. So say you're organized, your financial system is organized such that you've got a bunch of different programs. They are your cost centers. And so you run your financial report, and it's showing all those different program costs, and you're doing it by object code, because basically a lot of this is kind of object code level type stuff. You don't need to take the cost of a direct cost center and pull it out as an indirect cost. So, say it's $1 million, this one program, and yes, you may have, for example, utilities in that occurring in that program. Those, the entire cost would all just show up on the bottom line for your non-hospital mode costs. Really, what this represents is when you've got one of these type of costs that from your accounting system doesn't automatically fit into either admin, UR, or services. So, like, let's see, what's the, like contracts administration. So say you've got one person who does contracts administration, and part of their contracts administration, and this is kind of probably a little more fine-tuned than you want to get, but part of their time is spent doing contracts with providers, and part of it's just doing regular county-type contracting. But from your accounting system, you can't identify how much is on either. So you probably start off by reporting that person's cost as contract administration as an indirect cost. And then ultimately, and actually they changed it this year, so maybe this won't work. You're going to want to reclassify it or adjust it, or allocate it, I guess, is what you're going to have to do, into the direct cost centers based on a statistic. In this case, it would probably be percent of time that the individual spent doing that activity. And so that does bring up another point. They did change the order of some of the things on the right, but to print it all on here, it would be too small. And that actually caught me off guard on Friday as I was putting this together, because I hadn't actually looked at these forms till Friday. And so it's a little different this year. I think parts of it, the way they did, made it a little easier, and some things made it a little bit more difficult. But in this case, that would have been something that before you would reclassify. Now it's going to be a little bit more difficult. So I don't think they totally got it right. But did everybody kind of get this? I mean, because how many of you actually reported many of these costs up in the indirect cost area? No, Calaveras does.
I was, oh, okay. Yeah.
Actually, Tony does too.
So I was happy to hear you say that we didn't need to pull out costs that we've already identified as direct service costs or remote costs and put them up there and then reallocate them back.
No.
That's because I didn't do that, and I've been kind of stressed out about that.
No, I mean, again, so the type of stuff that you would fall up here often is going to be, like, say, because the other thing is, what you call maybe administration or your administrative division isn't necessarily the same as these administrative costs, right? So say you run a report for your administrative division, and you can't just automatically assign 100% of the cost down there. You may have to populate this with that administrative division cost and then allocate it later between administration and direct services, and you are potentially, you are as well, based on statistics. So, but for all your clinics, all that just goes right here. Your contract providers, to the extent you're contracting with community-based organizations, all that goes on there to start with.
So when you say you allocate them, you use the reclass to allocate them.
No, so last year, 11-12, you would have used the reclass.
Okay, I guess.
And technically, the state still hasn't got this right. They're trying, but there really should be a reclass right after this to where you can do that. The problem was that the state said, we want you to use that reclass to also allocate, like admin, into how much is Medi-Cal. And so once you do that, all of a sudden now all the adjustments have to be done at that level. In 11-12, that was a nightmare. I don't know how many of you did that, but you ended up having to take, so for example, say your ADP costs are in here and you need to back those out. Well, you've already done the reclasses, spread things into Medi-Cal, non-Medi-Cal, and all of a sudden now you got to back out ADP out of each one of those lines. It was a real pain in 11-12. So they did fix that. The problem is now what I was talking about, it doesn't allow you to do that. So I think it becomes part of your indirect allocation. So you would identify the costs, up here, because you can't directly assign it to one. You get to the indirect, which we'll talk about, and you would just have to allocate it down to these based on, like I said, statistics. So it's going to make that a little bit more difficult, the indirect cost allocation. But generally, you're probably not going to have a ton of costs up here. You just aren't. I mean, most of the stuff is you're going to pretty much identify right out of your financial system. Anybody else have questions on 1960? And so, again, that's what I said there. And so then after we have you've basically downloaded your financial report into the 1960, we then make a bunch of adjustments. And there's really 3 forms to make adjustments, and then there's a form to do reclassifications, and then there's the allocation of the indirects. And so 1961 is used to adjust the costs. They call it the Medi-Cal adjustments. Really, these adjustments should tie back to what's in the provider reimbursement manual in terms of defining what an allowable cost is. Give you an example, lobbying expenses that you pay to CiMH are not allowed. They're a non-allowable cost. Those should be adjusted out. If any of you are self-insured with your workers' compensation claims, those are not an allowable cost as a payroll deduction, but the actual claims are an allowable cost. So those would be another example. Depreciation might be another example. And on the form itself, which I'll get to in a minute, it lists out a bunch of examples. But really, the way I differentiate the 1961 from the 1962 is purely based on what are you doing because Medi-Cal says you can't do it or you have to do it. That's what the 1961 is used for, while the 1962 is for where you make other adjustments to get to really what were the costs of providing the services that we've already identified on Schedule B. And those would be, for example, your accruals. You know, if you captured the state hospital offsets to realignment as an expenditure, you would back those out here. Same with the managed care, the fee-for-service Medi-Cal inpatient offsets to realignment. And again, the reason is you're not reporting any services anywhere on your cost report associated with either state hospital or units provided in the hospital that would be a result of or cause those offsets. That's why you back those out. This is where you do your ADP costs. You may have some residential costs. And in some cases, your 87 costs are not in your general ledger, your trial balance, so you have to add them back in. And this would be the place where you add those costs in. And really, again, with the goal of trying to adjust, because you didn't do any adjustment. We used to do a lot of this stuff actually before we even got to the cost report. But now they want to see it, and so it's really a way to adjust what's shown in your financial system to reflect the services provided in that fiscal year that you're reporting on your Schedule B. So, it's advantageous to leave in as much as possible, but you need to have the services there. And so, you know, you aren't showing hospital days anywhere on the state hospital days, nor are you showing the Medi-Cal fee-for-service Medi-Cal inpatient hospital days anywhere on your cost report. So you need to back those out. The one thing you wouldn't back out is what we talked about earlier, is if you're using some of your managed care allocation, which you don't have anymore, to pay for indigent care, you wouldn't back that out because you are going to report those days.
Wouldn't those be reported on a separate legal entity cost report, though, not the
It could be. I mean, so definitely the Medi-Cal stuff has to be. But for the non-Medi-Cal stuff, like this hospital thing, it sounds like the state allowed you to report that on the county's legal entity cost report rather than creating a separate legal entity for the fee-for-service hospital. It actually might have caused some problems.
You can't report it on your cost report because you didn't provide the service.
What's that?
We did have a different legal entity.
You did have a separate legal entity.
Yeah.
So you
separate
did back
legal
out their
entities.
cost there. Okay.
No,
And then reported on a separate legal entity cost report.
yeah.
Comes off on
So,
the
Yeah, so
it
you're
comes
right.
with
It is
all
a
the
separate.
contractors.
1963.
But that would have been another way to do it, maybe.
Yeah, see, there's no Medi-Cal, so maybe I don't know what they're doing on the edits to.
Well, they at least asked me to provide a note for the file and give it to them.
So again, these are things where you're not, and then the 1963 is where you're getting the payments to contract providers that also file a cost report, which actually sounds like that's how this hospital thing was addressed.
Because your board and care is any other entity that you pay, you're going to report that as a legal entity cost report. You're not going to report that as part of your MHP cost report.
Correct.
And then, so the hospitals kind of follow that logic that you report them separately and break it out as a contractor payment on 63.
But on the board and care, you can.
You can report those as yours?
Under our cost,
Yeah.
So we do them as separate legal entities. Does it matter?
It doesn't, because there's no Medi-Cal involved.
Right.
So, and that's why, when I say residential, some people back some of that stuff out here. This is more potentially like out of state type stuff. But ultimately what you're trying to do through the adjustments is make adjustments to get to, here's how much it costs me to provide these services. So, and these services are what you're showing on Schedule B. But at the same time, to the extent that you've got some costs that, especially with MHSA, where you're not getting a cost report from the entity that you contracted with, and the services are not, they're primarily mode 60, for example, you're not going to want to back out those costs, and you're going to want to call them your own, because a lot of these times these are, community organizations. They're not Medi-Cal certified, so they don't have a legal entity number, but you need to make sure you get credit for the costs that you're incurring for all MHSA. So in those cases, you leave those in, and you just report it as a mode 60, service section 78 typically, type of cost, as if it was you providing the services, even though it's a different entity.
And also you want to remember that some of these costs that you're backing out may be, well, like the lobbying expenses. Those are still reimbursable, but not under Medi-Cal. So for purposes of your total revenues that you report, I have a worksheet where I show all of my realignment, for example, and for some of these that are reimbursable to the county. I mean, the county can use realignment funds to pay for it. That I show that there's that much less realignment revenue put on the 1992 because I need to cover those costs somewhere.
Yes. Yep.
And if you don't do that, somewhere it's going to get lost in your internal system that you won't cover those costs.
Right. Which when we get to 1992, I'll talk a little bit about that, how that number that shows up as realignment, there's no way the state can reconcile it. Right. But you'd have the same thing with the state hospital offsets, and even, actually probably not so much the state hospital, but the managed care offsets to realignment. Technically, you should be using your managed care allocation to cover those costs, not realignment. The state does it against realignment because that was easy for them to do. So that would be another one that you'd have to look at in terms of what was the funding source that you used to cover the expense. But yeah, and the same thing with these the workers' comp costs. It's only a Medi-Cal issue. In fact, actually, it should be just the one that you're showing on the 1961 more than likely. Would be the ones that you'd have to do what Gary talked about, which is make sure you're accounting for a funding source somehow to pay for whatever you backed out as the cost report. All right, now let's just take a look at the forms. So, like I said, the 61, we've got some examples that they've identified. They're pulling those directly from the provider reimbursement manual. And so, you can use these. You put the amount of the adjustment This is the line number on the 1960, and then I think it auto-populates the description. But most of this is not relevant. And then the 1962. So again, when they did the reclasses early last time, you basically had to have multiple lines for each one of these one adjustments. So now they fixed that, so it makes it a lot easier. But then here are your other adjustments. You got your accruals. You know, you're gonna have prior year stuff that you're backing out. You're gonna take, you know, any expenditures in the subsequent year, add those back in that were made for the year that the services were provided. Ultimately, trying to get at here's how much it costs me to provide these services. And it's the same thing. You put a description in of the adjustment, the amount, the line number from 1960, and then it auto-populates. And then the 63 is, again, for the contract providers. And so here, you've got to put the legal entity name, number, the total payments to them, and then you take the total payment, and then you've got subsets of that total payment. So if you had strictly a Medi-Cal provider, that total payments would then be reflected in these various program lines to where they're equal. If you paid that provider for some indigent care as well, then these will not add up to the total payment. And I'll show you this in a little bit, but what really starts to become important is column E through K in terms of determining what were your certified public expenditures. E determines how much they're going to take out of your trial balance or your general ledger, but ultimately E through K is what determines how much were your certified public expenditures. And again, it's, you know, the programs are basically driven by aid code, with the exception of MA. To the extent that you're paying a provider for MA, you would identify that separately. I'm not totally sure why they did that, but in any case, they've asked you to break that out. And you know, the other part of this, so you got, there's a couple of things. So say you've got a provider that's showing that you paid them $1 million on your GL, but part of that payment was for a prior year, and it doesn't include how much you fully paid them because you've got a payment in the current year that you need to add in. So you make an adjustment, for example, on the 1962 to get to the correct amount that you paid them, and then put the total payment here. It's kind of a hassle, and this form gets updated when you do the reconciliation and potentially even audit as you're settling with providers and making payments to providers. But it's ultimately to determine your certified public expenditures.
How would you recommend if you have a contractor payback?
Where they pay you?
Subsequent.
Or
yeah, they pay us back because of
you only pay them.
No, we have findings, and then then our internal auditors are saying, okay, you have to pay us back. Now we get the money back, but it's free. It's 4 years after the fact. How should we?
Prior to audit.
Yeah.
I mean, you should be adjusting. You should be adjusting both the 1963 and the 1962. That's what I'm saying.
To accrual, and then when you do audit, we should adjust then for those paybacks.
Yes.
And they need to adjust the legal entity cost report as well.
Not necessarily their cost report, because they should be showing you their total cost. It depends on what you did on their cost report.
Right, but if you don't reduce it to what you paid them, it'll mess up when you roll it up the summary. Won't it?
I'll show you. So there's some stuff on the 1900 on the contract provider's cost report that if you had made some adjustments on there, you may need to modify those. But if their costs are just their costs, and what's being recouped is because for example, the charts didn't support the units, you still would keep their cost as their cost because they provided those services. It's just the units aren't Medi-Cal.
No, I thought you said that they settled because if there's cost settlement on their contract. I thought you were saying they were settling the cost. I'm sorry.
No,
Is it just
an
units?
example, but
It's hard to hear.
But it depends on the stuff. I mean, because ultimately what drives your settlement with your contractors is not necessarily the cost report. It's the agreement you have between you and the contractor. But you could have instances where, because of a payback, you are going to have to adjust their cost report. Do all of you have contract providers? Or, yeah, quite a few. All right. So this now is the allocation of the indirect costs, which is shown on there, and you do that on the column H of 1960. So they want you to I previously have used the gross cost approach when you don't have statistics. So for example, if you've got A87 costs, I would look at how much is the gross cost of each of these different cost centers, admin, UR, and your non-hospital mode costs relative to each other, and allocate my 87 that way. In cases like we were talking about earlier, where you're actually having to allocate, it's not even an allocation, you're assigning indirect costs, like it is an allocation, for a contract manager who's doing both contracting with providers as part of the mental health plan, which is admin, and also just doing regular county contracting, which is could be more of a mode cost. You would split those costs based on the actual staff time spent doing each activity. But if you've got some generic indirect costs, I generally just apply a gross cost sort of approach. And then, again, they switched this up this year. So they did indirects, and then they're doing the reclassifications. So now what they're really doing with the reclassification isn't what it was intended to do. Because the reclassification was intended to say, hey, I've got a cost center that has more than one type of cost in it. It's got admin plus it's got a mode, or it's admin plus UR. And so I could reclassify some of those costs, again, based on a statistic. What they're solely, I think, using it for now is to take your total admin and your total UR and put it into how much is in each of the different programs. So that's a different approach to 1213 than what we did in 1112. And so you can kind of see that. Well, here you've got the 1965, and so what you're going to do is you're going to have, for example, a line called administration. You just give it a code. The cost center is the name of the cost center, and then so these are the increases and these are the decreases. So you would say I've got admin, then I'm now going to split into Medi-Cal, healthy families, and non-Medi-Cal, let's say. And so you'd have admin as one line, and you would show it as a decrease in your total admin, and then you'd spread it into the three different lines that encompass those costs. But again, this wasn't really those really should be allocations or apportionments between those different, but they're using the reclass to do it, which again isn't technically the way it's done on other federal cost reports. And so you can see that on the 1960, again, we came up with our total cost there. All this stuff just feeds in from the various schedules. The indirect cost is totaled here, and then you get to plug in the numbers there. Reclasses happen here, which actually, it doesn't make sense to have a reclass after you've allocated your indirect. So, I mean, they've even demonstrated themselves that it doesn't work. But anyway, so the reclass is mainly to take the total amount of admin and put it into the different admin programs, being Medi-Cal, Healthy Families, MCHIP, and non-Medi-Cal, and then doing this UR, how much is SPMP, non-SPMP, and non-Medi-Cal. And then ultimately it adds it back up and gets to the net cost on the 1960. And so again, remember when we looked at Schedule C, it said, does the amount on Schedule C equal the non-hospital node costs? And so that's what it's checking. It's checking this number against that number, and more than likely it's not going to match even if the numbers look the same on the screen. Really, this whole exercise that we just went through is just to support what you're showing on your Schedule C. That's it. This doesn't go anywhere. I mean, I guess the admin part does in the UR, but really this is the main purpose of this, is to show how you came up with your mode costs. It's pretty straightforward, still a little messy, a little easier this year with the reclasses happening after, but it still doesn't totally work. Because I know in some of the ones that some of the cost reports I prepare, I have reclasses where, for example, the healthcare agency costs are in administration to start with, but I want to get those allocated as indirect, so I have to pull them out. I'm not sure how I'm going to handle that. I'm probably going to have to take, because I used Reclassify to do it last time.
Couldn't you do an in and out of the 1962?
You could. I mean, that's really not what the 1962 is for, though. But because really, it should have been, these two should have been reversed. And actually, this shouldn't be happening here.
It should have a whole other column just to allocate your indirect and your indirect and your admin and your UR and allow you to have a reclass.
That's what I'm saying. It's more of an apportionment of your admin costs to those different programs, but whatever. It's all fun, right? Everybody get the 1960? All right, then we get into a bunch of auto-populate forms, and you'll see that it's all Schedule B, Schedule C. You know, in terms of how this stuff goes, the 1964 kind of a way, it does show your cost by mode, but you know, it doesn't really mean anything. 1966, you know, again, picks up the costs from Schedule C, and then the units from Schedule B. 68 is populating from the 1966, as well as some of the revenues from Schedule B. And then the 1979 auto-populates from a couple of different forms there. Just to point out a couple things, on the 1968, you'll see at the top, these should change depending on if you're going to be reimbursed based on costs or charges for each, actually it's not each mode, it's basically inpatient versus outpatient, but they still are applying the SMA to for admin days. But that really is, this tells you what reimbursement they're using, whether it's costs or charges. And again, there's no SMAs in 1213. So the 1900, I'm kind of going backwards here, but there's really three areas on the 1900, and the first two really relate more to your cost, your detail, the county's detailed cost report, And then the last one really relates to your contract provider's detailed cost report. So you've got these sections up here where they're asking you to put in the contract provider, other Medi-Cal direct service gross reimbursement. And they broke it out into 3 different programs: your regular Medi-Cal, the enhanced children, and healthy families. For inpatient, at a minimum, what you're going to have there for the straight Medi-Cal would be your managed care offset grossed up to reflect the full cost. So if in 1213 we had a 50% FMAP, so you would just take your managed care offset, assuming they're all regular Medi-Cal aid codes, and just gross it up times 2.
Doesn't that assume that the managed care offset applies to that fiscal year that you're doing the cost?
Yeah, based on when you actually, you have to look at the dates of service of the offset, which is identified on the State Controller's Office website. It says the period of time covered by the offset.
The period of time that they did the offset, but you don't know what the date of service is.
That's the service date.
Yeah.
It's the service date covered by the offset. On the realignment
I know on your managed care offset that comes off your funding,
right.
But
it gives you a period of time on there for when the services were provided.
I just looked at that recently, and it goes
I
from the
don't
middle
think
of
that's
September
true.
to the
Yeah,
middle
no,
of
it's-
October.
Right.
it's based on when the hospital actually finally billed it. It wouldn't
Right.
necessarily relate to
It should be based on date of service.
Yeah, but that's the problem with the managed care offset.
Right.
You don't know what
and I
it's
know
for.
nobody can reconcile it, and
Right.
it's a nightmare, but.
But if the hospital doesn't bill for 30 to 60 days out, which would be reasonable,
Or
there's
they
no
have
way
problems
that date.
billing.
Huh?
If they have problems billing too.
Yeah,
that's the same
there's no
thing.
way that can necessarily be. But nobody knows either, so they can't ding you for it.
Right. And there used to be an edit where they check that amount against what you reported on your 1994, which we've been saying for years is improper because a lot of you spend more on inpatient services than you were getting in your managed care allocation. But I mean, you're going to want to try to put something in there. And all these lines do is increase the amount of the administrative reimbursement limit. So you're still limited to 15% for administrative costs, 15% of direct service costs. But they allow you to add in what you paid for inpatient and outpatient services outside of what you incurred as actually county operated. They allow you to add that in to determine that 15%. So for the outpatient services, you're going to look at your contract providers, the 1970 or the 1968, I think, and enter the total amount that they're showing that's used to determine the FFP on their cost report. You'll add all that up. But again, and then that then increases your limit on administrative reimbursement.
And Mike, isn't technically that part should be an auto-populate thing too, because it just comes off, that part comes off the cost?
It could be. I mean,
that's probably the biggest of all the errors that come through on the ECR after you're done with the cost report. I found that that's the biggest one, takes the most time of everybody involved. I don't know why they don't auto.
yeah, I don't know.
After seeing that. I mean, they see it on their side. They're calling you constantly.
Right.
On that one.
And then the other part is that they did have the audit. They still had the error correction on the inpatient, but they're assuming that you would never spend more on inpatient services than your managed care allocation.
Yeah, on that one would be a little more difficult.
But there's no managed care allocation anymore.
Yeah.
So anyway, that hopefully you were aware these lines existed and have been using them. Because actually, as Gary said, I think you're going to get back an error if it doesn't tie. So then this middle section is where you just plug in the provider numbers for, again, what I call your network providers or your fee-for-service Medi-Cal providers. And then this bottom section is really kind of confusing, but it's what so you're not going to modify this on your detailed cost report. This is where you would edit a contract provider's cost report to adjust what they're showing as FFP to bring it back to the amount that that you actually paid them. So, and the problem is you've got to go through, especially this one here, you've got to go through and figure out, okay, you got to look at the provider's cost report, figure out how much the excess FFP is, and then gross that up to get the amount here. Bottom line to me is, I don't know if I'd be messing with this. I mean, let them try to come back and say that your FFP is too much, especially in the case where you're submitting an initial cost report and you haven't settled with the provider yet. And the other part of this too is, I don't know, I'm not sure why we need this anymore when we've got that whole 1963 CPE calculation. But in any case, this does give you the ability to adjust, you know, the provider's cost report to reflect the certified public expenditures that you paid them.
That's kind of one of those things that, to me, you just settle it, taught it, forget it.
Yeah.
It's not usually much.
No. And the other part,
it's so confusing. It's just,
well, the other part too is you may, so, and I wasn't going to get into upper payment limit and stuff, but your upper payment limit is based on your total CPE, not CPE by provider. So you could have an example where you paid one provider less than what their costs are, but then another provider's costs were less than what you paid them, and net-net, it's the same, in which case you wouldn't want to make an adjustment on either because it will come down to your actual CPE. So, again, that's why I'd be a little careful or cautious on messing with this section. I think it was more relevant before they've added some of this other stuff around the CPE.
But don't you have to adjust it if their cost is higher than what you paid them? Don't you have to adjust that so when you roll it up, it works out in the summary?
So you're reporting on your 1963 how much you paid them, but like I said, you could have an example where you paid a provider more than their costs, depending on the term. Especially any of you contract.
I get that it adjusts and everything. If you have one that's low and one that's high.
Because this is going to adjust the FFP. So if you go in and mess with this, it would show a lower FFP amount. So then you wouldn't get credit for it in the case if you paid another provider above their cost. You see, and yeah.
Yeah, I've never been very clear on exactly how they're expecting that to work.
And
be able to work correctly and reflect that as well.
But I think that was the initial intent, was to allow you, when they were thinking of doing CPE by provider, they were looking at this, and technically that no longer is consistent with this whole concept of upper payment limit. So anyway, but in general, I mean, well, no, I guess you could. There are providers that try to inflate their costs or have high costs, especially for those of you who have instituted or maintained kind of the SMAs. You may have instances where the costs do exceed, and if they're significant, you may want to go in and try to adjust it. But I think you need to do the actual calculation outside of this worksheet, and then you just plug a number into here. All right, then we've got this other new form that they added, the 1979B, which it's a new form. and it is trying to get at, like I said, this whole concept of certified public expenditures. You don't have to do anything with it, but you probably want to look at it. So the county stuff on your cost report is all coming from the, where's it come from? Probably 1979, yeah. So whatever and you're actually not reporting anything on the 79, but the 79 auto-populates, and then the MH 1979 auto-populates everything for the county. For the contract providers, these amounts are all coming from what you input into the MH 1963. So where you said, here's how much we paid our contract providers, here's how much was Medi-Cal, et cetera, that is then flowing into this to come up with the total certified public expenditures, and then applying the FMAP and coming up with FFT. I don't know what they're going to do with this. I don't know if this is the way they're going to look at it in aggregate to figure out the FFT, or if they're then going to take this. I don't know. I really don't. Until we see the detailed cost report, kind of anybody's guess. Are they then going to say, well, this is your FFT, and that's what we're going to reconcile with? I don't know, but you don't have to put anything in here, but you do want to pay attention to it.
Is this the county legal entity report or the summary?
This is a detailed cost report. So even in the contractor cost report, I'm guessing they've got a macro that's going to just not populate any of it. So it would only populate on the county detailed cost report, and I'm guessing it's going to somehow feed into the summary, but until we see the summary, it's kind of a guess. Anyway, it is a new form, so when you see this 1979B, don't totally freak out.
The old 1979 there, right?
Yes, it is. So that the old 1979, and I didn't print out all the auto-populate ones. They pretty much look the same. The one nice thing, though, is that because we have the same FMAP for the whole fiscal year, we don't have multiple lines, so it's not like super huge. All right, so then we go into the 1992 for revenues. And so here it pulls, the gross cost directly from the I forget if it's the 66 or the 68 where it's pulling it from. But then it gives you this line that you can make an adjustment on, and this again is more for your contract providers. And so in some cases, especially for some of the residential services where you've got one provider that furnishes services to all counties, or not all counties, but to beneficiaries of multiple counties, that provider has the option to do just one cost report and then report the Medi-Cal units applicable to each county. So you may have a gross cost here that's way in excess of what you contracted with. You may want to adjust that down here to get to really the cost that you're dealing with that provider. It's not used that frequently, but it does give you the ability to do that. Because then you've got to identify the funding of those adjusted costs. The other way you could actually deal with that is to put it as another revenue. The downside is if every county did that, it would overstate the actual expenditures if anybody ever aggregates these cost reports. But so then you've got the various revenues, the grants, station fees. It's, I think, pretty straightforward. Probably the one, well, actually there are, so this year we now have this 2011 realignment, which is your behavioral health sub-account. So to the extent that you're using funds from that behavioral health sub-account for any of these services, you're going to want to reflect that on there, which would include those, if you're using it for EPSDT, if you're using it for what you traditionally would have used your managed care allocation for, you would show that there. And like I said, your 1991 realignment's on there as well, but you're not going to be able to reconcile or the state isn't that number back to your actual distribution. Probably the hardest number I think to come up with is the MHSA number, because that reflects the actual amount of MHSA funds that you used for each of these services, net of any FFP or behavioral health subaccount or any other revenues that might have gone into an MHSA program. So again, you're probably setting up a separate schedule somewhere to calculate that, here's the units that were provided in that MHSA program, and here's the resulting revenue. I net that out, and that's what I reflect on here. Anybody have any questions on that, on the 1992? I mean, it's kind of a pain. It's, you know, most of these you want to tie back to your financial system. The one, you know, a lot of times the overmatch becomes a plugged number. You know, recognizing that more than likely the FFP number isn't tying exactly to what's in your budget and what's in your financial statement.
Because we don't get cash when this is accrual and the other something else.
Right.
That's why it's really important to have your other papers show, you know, your 1961 offsets from your revenue,
Right.
and have a separate sheet to work all that out, and then just plug it in here.
So I have a question about, so they're asking us to report the 91 realignment and then the 2011 realignment?
Yes.
So is there a recommendation on which, so we should fully spend our 91 before we're?
I go the opposite.
You would do the opposite?
Yeah, I mean, so, well, because you've got more flexibility with your 91,
Right.
Your 2011 has to either be EPSDT, managed care, which is actually broad,
Okay.
or, you know, substance use disorders. So, actually, it probably doesn't really matter. I don't know what they're going to do.
Yeah.
Again, why, you know, they want to make sure you spent it entirely. It's, you know, is it going to end up kind of like the 91 line that they can't reconcile to, and so it's basically just a way for you to show how you funded your programs, or are they going to try to reconcile, because we may see, I didn't think about this, we may see in the summary that they actually start to put a form in for the behavioral health subaccount, similar to the 1994 and 1995, saying here's how much you got in your behavioral health subaccount, how much did you spend on EPSDT, how much on managed care.
But Mike, they can't do that because part of it's for substance abuse, and you have flexibility in how you allocate those funds between those 5 different buckets. Well, for us, it's 5 buckets in the behavioral health subaccount. So there'll never be a number that they could actually tie to because they don't know how you're allocating it within your own system, because they're just giving you a number, and you've had to come up with your own basis for allocation. So there's no way they could tie out to it unless they someday combine the 2 cost reports, which I don't think they ever will.
Right, so that's what I was wondering politically, if there's a,
Yeah.
you know, we would want to not underspend one or the other.
I don't think you want to underspend, no.
We don't want to underspend any of them.
You're better off underspending 91 than the behavioral health subaccount, I think. So, because, again, they're, politically, 91 really hasn't been, you know, that much attacked or, you know, looked at in a lot of detail. There are a lot of programs that were realigned into that. While the behavioral health subaccount, we still have, you know, kids advocates that are really focused on that, and so I would think you'd want to spend, or at least show the expenditures. But like you said, I mean, it's the state published that info notice that said, here's how we calculated your percentage with the amount going into each pot. But the statute doesn't hold you to that amount for each pot, whether it's, you know, whether you count 5 pots or 3 pots, or you could actually even go more. So I don't know. You know,
won't they be looking at the 2000 realignment for growth? So if you are overextending,
I mean, if you're maxing out your 2011 in the
Actually,
future,
you know what?
you'll want to make sure that you're using
I didn't
that.
say, this is 1213. No, we did have 2011 realignment. Yeah, 11, 12 we didn't.
So you'll definitely want to use your 2011 realignment
Yeah.
first.
But I don't know if they would use the cost, because they don't know how much is EPSDT and how much is managed care. I don't know. I just think you want to spend your 2011.
Okay.
Because, again, 91, you know, you don't have advocates really scrutinizing that closely. You know, we've got this new drug Medi-Cal benefit coming on board that there's going to be some potential state general fund for. So I just think spending your 2011 is a better shot.
I asked Chuck Anders what this form was used for in the cost report training that they did, and he didn't have much of an answer.
Yeah.
Has anyone ever been audited on what they show as revenue? I mean, it's never come up in an audit that I know, but I mean, they're so far behind the audits that they could bring that on you anytime. But
Yeah, I mean, even
I think they use it for some statistical type reporting or something, but it's not something that they're really.
yeah, because they've got to report to SAMHSA.
Yeah. So I mean, you pass your SAMHSA grant stuff on there usually, but the rest of it is.
Yeah. Because there's also the long-term health program stuff on here too, both the FFP and the match. And yeah, so I don't know. I don't know what they're going to do with it. Because again, we haven't seen what the summary is going to look like yet.
This is also a report where cash versus accrual basis comes into an issue too.
Right. So, which is, so you're reporting patient fees on a cash basis. So it's the, you know, they call it the modified accrual. But yeah, I've never had an audit finding related to my 1992. So I don't. And also historically, so those who was around when we had the CRDC system? Somebody's got to be. Wow. So remember, we used to report some of this stuff through that, and so that was one of the we reported how funds were used. That was one of the trade-offs. We said, okay, go ahead and add this form, but then let's totally get rid of CRDC. And so that was kind of one of the agreements. And this is, I mean, and there are some functional elements to it because, for example, it does show, does your FFP, well, or I shouldn't say does your FFP, but do you not have sufficient matching funds to cover the FFP? But, you know, and that's one of the cross-checks that they look at. But
again, it's weird because it calculates the FFP based on the services that you put in the system in your cost. However, you're not getting that revenue for God only knows how long, and depending on when you bill it. But yet you have to use your revenue from the year that you're technically doing the cost report for the match. It's really not a good report as far as accuracy. Yeah, consistency or, you know.
Right.
You know, basic accounting principles.
Well, like I said, so you end up with, you end up with a bunch of, well, not a bunch, but you end up with a couple plus figures to make it tie out, so you pass.
They're definitely not looking at it because I have had old cost reports that I've been involved in working with counties where they had twice as much realignment that they used than they had.
Yeah.
Nobody
Ever questioned. Yeah.
Yeah.
I don't. There are very few people at the state that deal with this that even would understand realignment. More would probably understand 2011 realignment, but even there, I mean, as we talked in the last Financial Services Committee, they kind of didn't know what they were talking about. But anyway, that's it. A little So, and that just talks about some of that stuff. So let's talk about lower cost of charges a little bit, which, you know, it may be an issue or may not be, because if they start to get into really pushing, and there have been some audit issues around this, if they get into really pushing the lower cost of charges, when we look at the supplemental claim going back to January 1st, 2009, and it may not be as relevant to you guys that are small counties who are below SMA if you would set your published charges. But I think it's worth at least mentioning to you guys. So there's a section of 42 Code of Federal Regulations that requires providers to be reimbursed based on the lesser of reasonable costs or customary charges. And you got to do it separately for inpatient versus outpatient services. And so, again, it's customary charges, not this whole published charge thing that the state uses a lot. So, although they will say in the manual, they'll say published charge means the usual and customary charge. But there's also a provision that says public providers that furnish services free of charge or at a nominal charge are exempt from the lower cost of charges. And so this 1969 form was developed by the state to look at the whole nominal fee provisions and to give you, does anybody use the 1969, the CiMH 1969? Okay. Okay. So it is, you're hitting up against it a little bit in some cases where your costs are exceeding your charges.
But it probably depends on how you fill it out.
We use it for.
I haven't had any problem.
Okay. So the 1969 is the form that the state uses to look at this. They have 4 requirements, and the one, you know, that has been somewhat difficult is this indigency allowances. So you're required to document basically your write-offs. The state, some of the auditors have said that write-off has to be reflected in your accounting system. And nowhere does it say that in federal regs or in the provider reimbursement manual. It's just some individual auditor's interpretation. So they have kind of done or gotten some people around that saying that wasn't met. But the form itself, so assuming you can meet all those 4 requirements, the form itself, for the most part, should be somewhat easy to complete. You put in the amount that you bill to Medi-Cal again, which should just come from your billing system. And it's this revenue part for non-Medicare and non-Medi-Cal services that might be a little bit more difficult. So the patient revenue is how much you actually bill folks for services. And so again, based on the UMDAP. The insurance is what you actually collected from insurance for these clients. And then you plug in on line 5, what, had you billed them your usual and customary charge, what would those charges have represented? Calculate the ratio, applies that against the amount billed to Medi-Cal. You plug in, or actually the Medi-Cal costs are auto-populated, from the 1968, and then it calculates 60%. And if your 60% of your costs exceed your adjusted customary charges, then you are exempt from having to do the lower cost or charges, and you are reimbursed based on actual costs. So it's kind of tedious to do, but in some cases, if you get into a situation where you go through your detailed cost report and you look at the 1968 and see that you're being limited by your charges, you're going to want to do this to get exempt from having to compare your charges. Again, CiMHCA's position is we shouldn't even have to do this. We're government entities, we should get reimbursed actual costs, but the state is still applying this form. So, but yeah, it's something you definitely want to look at. And then that's it for the detailed cost report. We've got the summary cost report, which as of earlier today, the state has not released it. I thought I heard somebody say mid-November that they're thinking of releasing it. I'd heard some things that maybe they're not releasing it because they're trying to figure out how to apply the upper payment limit and the certified public expenditure. That there's several forms that were used previously for state general fund. Identification, 1908, 1909, and 1994. I'm not sure, I mean, theoretically, we don't get state general fund anymore. We shouldn't need those forms. But, once you've started reporting the data, a lot of times the state wants you to continue. So I don't know if they're going to eliminate those. Whether the 1912, again, which was, the whole special education pupil expenditures, I don't think it's applicable anymore. They do have a federal IDEA fund line on the revenue if you want to report it, but I don't think you should have to do the 1912. But again, we'll see. Like I said, I don't know if they're going to do something with the behavioral health sub-account. Who knows? The summary, there really isn't much to do. Once you take out the general fund forms and the special education pupil forms, there's not much left to it. It rolls up the county and contract provider data, so you can look at some summary statistics, summary FFP, and then you've got to complete the 1995, which is just your MHSA expenditures, and really your expenditures for the most part are probably going to tie to the summary 1992 that you're showing your MHSA line. And so really you're just identifying how much interest you earned on your local mental health services fund. And then the fund balance, which really isn't the unspent fund balance because part of that is your prudent reserve. The one thing I will say is that we saw a draft, it was a while ago, probably 8-9 months ago, where they were potentially looking at taking that 1995 and putting it into the MHSA components. So having you identify all that by component. We said, well, you're kind of doing that on the revenue and expenditure report, so why do it here? So hopefully that isn't another reason that they're holding this thing up. The 1940 used to be really difficult to complete. I could never figure it out. But now there's just one number you got to put in, and it's the other funds number, and generally you would have spent that much of other funds, and you got to sign and certify it, and that's it. So, unfortunately, we don't have it released. Anybody have any questions on it? I don't know what else to really say on it at this point. Again, hopefully they eliminate a bunch of stuff off of it. Probably not, but a lot of it shouldn't be applicable anymore. And then cost settlement process. I mean, I think most of you probably know this. You submit your initial cost report by December 31st, so 6 months after the close of the fiscal year. The main thing that really needs to be accurate at that point, besides clearing all the edits, is that you want your total cost to be accurate and your total units to be accurate, so that the cost per unit is accurate. Because previously they haven't allowed us to modify some of those amounts. The reality is your initial settlement or your initial submittal does not result in any settlement with the state. It just sits there until you do the reconciled cost report, which should be done 18 months following the close of the fiscal year. In this particular case this year, what we just did 9/10. Yeah. So, almost 3 years, 2 years following the close of the fiscal year, so they're way behind. It's the reconciliation that becomes important in terms of getting your Medi-Cal units accurate, because that will result in a settlement with the state. Again, I believe you should report your Medi-Cal units that you think ultimately will get approved, regardless of whether they're approved at the time you do the reconciliation. As we all know, or not all of us, but like definitely Butte knows that you've got some units that you're not even able to submit because they're so old that meds can't tell you whether they were eligible or not. So more than likely, ultimately, they'll get approved, so I would include services like that, regardless of whether the state has said it's approved or not. And so you do have some discretion over what Medi-Cal units you're reporting. I wouldn't include denied units, but again, you may want to look at including units that have not yet been processed. You should, in the reconciliation process, have the ability to adjust contract provider payments on the 1963 as you settle with your contractors, because they're going to submit, I know definitely in several counties, the providers submit a cost report that just goes into, that gets filed, and it isn't until the reconciliation process when you're going to get paid that the county actually settles with the contractors. So you should have the ability to adjust your amounts on the 1963. And then they audit you within 3 years. The statute actually says they have to audit within 3 years of the most recently filed amended cost report. And unfortunately, most of the audit is spent looking at units of service versus looking at how you did your cost finding, which generally in other audits is what they do. And as we talked earlier, there definitely are some issues with the auditors, especially in terms of standardization across the auditors. It chews up so much time in appeals and everything else, but given what we've got in terms of this process, that's just kind of where we're at. Anybody questions there?
What if they don't audit you within 3 years?
So that's a good question, because I was working with an attorney that deals with appeals. He's really surprised nobody's ever challenged that.
Lake County did a while back, and it didn't do us any good.
Was it over the 3 year period?
I wasn't there yet, but I was told that one other audit that they appealed, they said that they weren't within their limits, and they didn't take that into consideration. The officer didn't, the hearing officer?
Well, yeah. I mean, I think it's definitely something to look at. If they're outside of this, but it's because the one thing you could do to really mess with them is you file your initial cost report, and then you don't make any changes. Technically, that should start the 3 year period.
You can't. You have to resubmit during reconciliation, whether you have changes or not.
So that's even if you don't make changes.
Yeah, because that's what I did with the 910.
I'll forget that.
But technically, it's not amended if you file the same one. So you could argue it on a legal point.
Yeah. So, yeah, it's not fun. And anyway.
Yeah. So is the most recent amended cost report, if you went to ICWS and looked at the date that it was last uploaded, that would be the most recent?
I would think so.
Yeah.
I mean,
I think it's based on the certification.
Not based on the bill.
But you have to recertify.
So when you actually sign it.
You have to recertify.
You have to recertify every
usually
time you
the
resubmit.
days of the.
Because I have to resubmit my 0910 again because of an error that was made on it, and I have to recertify it.
Yeah. Even if you don't make changes, you have to recertify.
Okay. We had a couple of questions that were filed. It's 4 o'clock, right? Yeah. So we did have some questions that were asked that I did put into here, and then I'll take others if anybody has anything. But the question was asked was, should we adjust the state hospital offsets and the managed care offsets to realignment? Should they be backed out, and if so, where? And yes, again, the state hospital offsets to realignment and the managed care offsets, assuming that you're booking realignment gross, so you're booking the full revenue and you're booking the offset as an expenditure, you're going to want to back those out of your cost report on the 1962 because those expenditures do not relate to the services you're reflecting on your cost report. Does everybody do this, or does anybody not Anybody not back out your managed care offsets or your state hospital offsets? Everybody know what I'm talking about?
A lot of people report it net on the general ledger.
Yeah.
And so you wouldn't have to back it out if you report it net.
Correct.
I just changed to doing it where it's gross and show the expense, so I'll have to back it out. But otherwise, there's no visibility on reporting.
The ones, I'm trying to think, actually. The main ones that I've been working on lately, we definitely do this. But yeah, it depends on how you capture, whether you capture net or gross 1991 realignment. There was another question on the 15% admin limit, and just so you guys know, so AB 1297 eliminated the schedule maximum allowances, but did not eliminate the 15% admin limit. So that limit is still in effect, kind of as we went through, and it's applied on the MH 1979. So that is still in effect. The AB 1297 eliminated the SMAs, so we didn't see those on the cost report for 1213. The other thing is we've got the supplemental payment state plan amendment coming up, hopefully sometime this fiscal year, and that will allow you to get reimbursed retrospectively back to January 1st, 2009 if you had costs in excess of the SMA.
So that will be done not through the cost report, it will be done through a different mechanism?
We're hoping that it's done in conjunction with the cost report. So it's literally take the numbers from the cost report, put it on a one-page form, and sign it.
Okay, because I have informally been told that unless we can qualify for the nominal fee provider, that we will not be allowed for those prior years.
Okay.
Because, like for example, like many other counties probably did, you did your published, or what you put in as through your board, which they call your published charges, you put those at the SMA because what's the benefit in putting it higher? And I also heard they did formal training in the audit division
On that specific.
on the nominal fee provider
Recently?
determination. Yes.
Well, that's good, I guess, assuming that they are training on the federal requirements versus their own interpretation or their own stuff. I think if they push that line real hard, some counties have some pretty big dollars at stake. I wouldn't be, and there was a specific statute requiring the state to pursue this based on certified public expenditures. It'll get challenged in court.
Yeah.
So I think it'll be beyond just a hearing officer, because LA has probably hundreds of millions of dollars at stake. So, so we'll see. Talking about, let me talk about this a little bit. When should you reconcile with your contract providers? And generally, you want to do that at least before submitting the reconciled cost report to the state, because that's when they're going to generate payments. You don't have to reconcile, when they submit their initial, but definitely by the time you get to the reconciled cost report, you want to have all the payments to the contractor that they're going to receive. But I also want to point out, you are not required to pay contractors based on their actual costs. Your FFP may be determined based on the lower of their costs or charges, at least initially, until they look at the TPE. But really, your payment to your provider should be based on the terms of your agreement with that provider. There's nothing that precludes you from paying a provider a negotiated rate, or from paying a provider the lower of a negotiated rate for their actual costs. But it's just more how the FFP is determined. We talked a little bit already about this. When should you use the 1961 versus 1962 for adjustments? And again, for me, the 1961 is when you're making an adjustment for based on within the provider reimbursement manual, while the 1962 is making other adjustments to try to get your costs in line with the services that you provided and are reporting for that fiscal year. So, you know, when we talk about what if you have subsequent settlements for in a cost report, what do you do with those? Again, so you may be reporting it or reflecting it in your GL in that given year, and it's for 2 years prior, but you need to back that out of your cost report because it isn't a cost you incurred in providing the services that you reflect. I mean, again, I keep coming back to costs aligned with the services and whatever adjustments you need to make to get there. You're not going to adjust your GL or your trial balance, but you will make the adjustment on the cost report. And you would use the 1962 to make that adjustment. And then we had another question, you know, where do you enter the contract provider's rate? And there really isn't a place on the cost report, on the provider's cost report, to enter contracted rates. So if you have contracted rates that are different than the contractor's published charges, they should still, or their usual and customary charges, they still need to enter their usual customary charges on Schedule A. And like I was saying, you can use that CiMH 1900 lower portion on their cost report to adjust the FFP based on what you actually paid them, if in fact their costs are higher than what you paid them. But you may want to look at your overall picture before deciding whether you want to make that adjustment. So for those counties that ask questions, is that hopefully takes care of. And are there any other questions? We still have 45 minutes if you guys want to keep going.
Like there's one that came online.
Where do we, the provider reimbursement manual, is that published?
So CMS.gov, where was it? I want to say it's like, so they've got a bunch of headings up top. I want to say it's regulations. Go into manual, and it's a paper-based manual. Or you could do a search for, because it's provider reimbursement manual 15-1. You could probably do a search on their website too. And I was just in it today. It's way more than you want to see. But you know, it is. You can at least look at the outline and see, does any of this apply? Because it goes to examples, and the other problem with it is it's not necessarily up to date. But I think in terms of how you're supposed to treat certain costs, it is. So, any other questions?
Just one for you.
Yeah.
How do you deal with if you have a provider who has like a maximum of $3 million and you realize in May you're at $3 million and they're still providing services in May and June? How do you report those units? Because you can't make the CPE because my auditor won't pay them anymore unless I amend the contract, but I'm not going to amend the contract because they're budgeting to spend actual cost of $3 million at the end of the year. But if I don't report the units, then I don't get credit for them.
Right.
What do you do?
So ideally, you've got like a mid-year sort of reconciliation process. Okay. So you catch it before you get too late in the year. But that still isn't going to preclude. We may have an instance where all of a sudden the units just spike up.
Yeah, I've heard of some counties like charging a penny a unit or something like that.
That's what LA did. You know, and went ahead and charged a penny a minute. But ideally, you would adjust the rate at a mid-year. There are other counties that do quarterly. You know, I think mid-year is good enough, but the other part, and we're going to talk about this, hopefully you guys are all going to the Fiscal Institute thing tomorrow. It really shows we got to get out of this type of system, because just the contracting headaches are a nightmare. You know, and trying to manage the CPE requirements, contracting on minutes of service, it just doesn't work. But you know, you either pay them minimal amounts. If you catch it early enough, you know, maybe it's not a penny, but it's like a buck or, 50 cents or whatever, still have them maintain a high published charge, or usual and customary charge. It's just what you are paying them becomes that rate. That's, or you don't submit the units, and like you said, you don't get credit for them.
Well, if you're not paying for the units, are you saying that your contract, they got up to their contract maximum, and so you're no longer going to pay them for any services? You're not going to cost settle with them later. It's just a matter of you're not going to pay for any more services?
Well, we can't pay for them unless we amend a contract, and we don't want to amend our contract because we don't want to give them money and then get it back at cost settlement. So we want to pay them $2.9 million for the year, and they budget for $2.9 million for the whole year, but the rates may start off a little high.
Well, how do you even bill that onto Medi-Cal if you're not paying for it? How do you have a CPE for it?
That was the question.
Yeah.
Okay.
And the key is to identify it before you hit the contract max, and make adjustments to the rate that you're paying them and reporting the CPE to lower that so you don't hit the 2.9 million in May, so that you can kind of balance it out and try to get through the year. But if you don't for some reason, it's because you could have an instance where, things look good, and all of a sudden their units for whatever reason shoot up, they got productive all of a sudden, and then you're stuck. I mean, it's, yeah.
So what you were saying, Mike, is that then you bill it to Medi-Cal at a penny per minute just to get the units billed and showing in there, and then at the end of the year you would average out the cost per unit of service at the end of the year, basically.
Yes.
But that would allow you to, even without making an actual payment?
No, you'd be making the payment based on the penny. So you still are incurring a CPE for that service, so you can get it approved. But the CPE is just really low. That's what I'm saying. You got to catch it before it hits the contract max.
I was gonna say, if you could get to the max of the contract, you're stuck.
Yeah, basically. You could do like a mid-year cost settlement, and have them, give you back some of the funds maybe that you already, and then you could then subsequently pay them back that way.
Well, the first time we did it is we paid really high, so that they'd owe us a lot of money at the end for that settlement, and then we tried to switch around the other way where we would owe them some money, and it just, neither one of those methods has worked really well for either one of us.
No, and again, it comes,
it's just tough to hit the target.
Yeah, I mean, it's a minute of service.
Dealing with the target, yeah.
You could even if you did encounters, you could probably get closer than trying to figure out minutes. But yeah, at this point, there's nothing really you can do.
Okay.
What if you just, that won't work in the rate, so pay them 1/12.
Well, if it's not a pure Medi-Cal contract, you can do that.
The problem is billing Medi-Cal for the services, because some months you have a lot of services, and some months you have very little services, like in the summer and in December. So it's tough to justify paying. I mean, I guess you just have to be constantly adjusting your rates.
Or the other part you can do is delay billing by 1 month. So you're paying them the 1/12, but you're always billing an extra 30 days in arrears. So basically, they've got 2 payments for the 1 month of service. So you are.
It's tough to figure out how much to bill Medi-Cal, because you got to bill Medi-Cal on a per minute rate, unless you're just dividing services per the 1/12. Is that what you're saying?
No. So say you get a $1.2 million contract, so you're paying them $100,000 a month.
Right.
Pay them for July. Pay them for August. Don't include their July services until you do your September Medi-Cal bill. So you've already paid them $200,000 for theoretically, 1 month's worth of CPE that you needed to incur.
So the auditors are never going to look at how much you paid them for a month and how much you billed for a month to make sure that matches up.
It shouldn't.
In total, it looks fine.
Yeah, because you're not doing a claim by legal entity. but it's not ideal. I mean,
Right, and then you're 2 months behind on cash flow.
Right, exactly, well,
I mean, yeah.
So, you're having to, so is it worth paying them the 1/12 or,
Because, I mean, when you look at it, at the end of the year, you're only gonna pay them your contract amount for whatever services they provided. So if you do it on the 1/12 basis, at the end of the year, it's balanced out.
Yes.
There's a lot of reconciliation though with the units, though. You gotta make sure you stay on top of the units a lot more than if you're paying.
My biller would absolutely hate that if I made her do that.
Yeah, I mean, we try.
The contractor would like it, but
Yeah.
Nothing would match, so it'd be a nice.
Right, that's the problem.
until you got to the end.
Okay.
All right, anything
Anything
else?
Pay at 12 and forget till.
Just, sorry, a silly question. For the cost reports for the contractor, just to confirm, on the 1960, their total costs go on the bottom line direct.
Yes.
I understand that part of that is, includes some of it's a loaded cost.
Yes. Yeah, because, they can't be the administrator of the mental health plan. They can't incur administration. I guess you could potentially delegate some of your UR activities, but you're probably not, because these would be UR activities that are in your MHP contract with the state. So all they can incur are non-hospital mode costs. They could, if they, some of them want to do it, and especially, if there are consultants out there who want to break it out so that they get more work and, make it all look nice. But bottom line, it all ends up in the same place.
Right.
So.
I just wanted to make sure that.
Yeah, no, and I've heard the state say that. So,
And Mike, Jim's question was for contract legal entity providers, they only have to put in the direct service cost on the bottom of the 1960. Is that what she said?
Yes. Yeah, just whatever, was that line 33? Pull up to 19. It's the non-hospital mode cost, the direct service cost. All right. Nothing else? Thank you. We'll see you guys tomorrow, hopefully. Got here a little early. Thanks.
All right, thank you. Thanks for your evaluation.